I'm MyMy. I'm a pediatric pulmonologist, and I feel honored to be in front of you to start thinking about respiratory care in patients with spinal muscular atrophy. It's quite interesting to me to be able to have this only be a really small subset of the conversation when prior to these therapies, this was the main conversation for families about respiratory care because the respiratory health was pretty much the lives of these patients to try to keep them alive. So if you can remember from the beginning of the day, we have these audience response, and the website you can go to is pullev.com, SMA19, or you can, I guess at the top doesn't have the text number, but you can go there. But what I'd like to know is if you could prioritize the following topics that you have the most questions about regarding respiratory care in patients with SMA. I think, hopefully this works. It's really just to get a sense of the audience and what people want to learn about. Cool. So learning about how do we treat chronic respiratory failure, how do we treat inspiratory muscle weakness, what is the actual pathophysiology of muscle weakness, how do you treat poor airway clearance, how do you evaluate these patients, and then treatment of acute respiratory failure. So Dr. Mayer will be covering some of these topics. Next this is more of a controversial question. Just rank the following chronic respiratory therapies in order of what you think is important to maintain the health maintain pulmonary health in patients with SMA. So assisted cough, antibiotics, assisted ventilation, mucolytic therapy, supplemental oxygen, physical therapy. And I feel like some of these topics are controversial because supplemental oxygen is considered a poison by the SMA parent community, and antibiotics I often use as a pulmonologist and get a lot of judgment through my antibiotic stewardship committee here. But thank you for your participation. So assisted ventilation and assisted cough, right on. And there are no right answers. So in the context of CME, so I present to you a scenario and just have two questions about it. So the scenario is a 3-year-old child with SMA type 1 who's been treated with nusinersen since 12 months of age and is treated with nocturnal non-invasive ventilation, who presents with new symptoms of a runny nose and increased oral secretions for just 1 day. On physical exam, the patient's afebrile, the respiratory rate is 60, the oxygen saturation is 90, and the breath sounds are diminished in the left lower lobe without any rhonchi. Abdominal breathing is present, and the patient is verbal but has a weak cough. So what is the most likely etiology of this patient's hypoxemia? And again, there's no one right answer. But the reason to even consider what the reason of the hypoxemia is so that way you know what to initiate first for therapy. So just to remind you, it's a 3-year-old treated with nusinersen, but still on non-invasive ventilation while asleep, is breathing at 60, and has an O2 sat of 90. So interestingly, most likely the underlying etiology may be URI, but one of the first things we'll think about is that mucus plugging can be a cause for acute hypoxemia, and that's one of the things you want to treat right away. In this scenario, so in context of what I just said, rank the most important acute respiratory therapy that could help with this patient's hypoxemia in your office or in the emergency room or urgent care. So the choices were assisted cough, antibiotics, chest physiotherapy, mucolytics, supplemental oxygen, assisted ventilation. Oh, I find the answer is very interesting. So as a pulmonologist, I would say assisted cough is number 1. Next was assisted ventilation because you need to stabilize this patient. Then comes the chest physiotherapy, the mucolytics, antibiotics, and last would be supplemental oxygen. Thank you. So next I'd like to introduce Hank Meyer. He's a pediatric pulmonologist from Children's Hospital of Philadelphia and definitely an expert in this topic. Thank you.
Excellent. Well, thank you again for the opportunity to speak. And I've had the opportunity to take care of a number of patients with neuromuscular disease, in part because Dr. Finkel pulled me out of my professional infancy and gave me a purpose. So thank you for that. So the other thing is there's been a lot of really interesting stuff presented this morning about sort of the new frontier in SMA care. And the one thing that wasn't said there is anything about a cure, which means that we still have clinical symptoms to manage. And as Mimi brought up, there are a number of issues related to both acute and chronic management of the respiratory issues in SMA, and I'd like to go through some of those. So I didn't have a disclosure, but I have been involved in both consulting and speaking on behalf of Biogen, and have consulted for Roche and Avexis, but none of that will influence the content of this. So we're going to talk some about the clinical progression of the respiratory morbidity in SMA, talk then about some specific management issues related to airway clearance and then ventilation. Then I want to finish by talking about issues related to acute management, going beyond the clinical plan that a patient may have. So with any neuromuscular condition, you start, at least in my world, with respiratory muscle weakness. Then the end game of this is respiratory failure. But if you then back up and look at what leads to respiratory failure, I like to think of three different components. I think of the diaphragm, which is the primary respiratory muscle, which does most of inspiration, and then the structure for the lungs, within which the lungs reside, meaning the chest wall, which involves chest wall muscles, which, as you know, in SMA can be exceptionally weak, and then the spine, so spinal instability related to chest wall muscle weakness. And then these are all interrelated. And so if we start on the left, if we look at diaphragm weakness, if you're not breathing in deeply, you begin to develop low lung volumes, and that has impact related to the lungs being small, airways being narrow, and that adds to inspiratory load. If you also have, if you have diaphragm weakness, it's also going to be very difficult to mount a good cough, which then, because of poor airway clearance, puts you at risk of having lower respiratory tract infections. And anytime you have an acute illness, that will decrease muscle strength and fatigue, which can put you at risk of respiratory insufficiency. If we then look at the chest wall muscle weakness and decreased mobility will eventually, either from contractures or chest wall distortion, lead to decreased chest wall compliance or a stiff chest wall, which also adds further to the respiratory burden and can limit lung volume. And then if we go over to the right, as the spine becomes distorted and twists, rotates either in a kyphotic front to back or in a scoliotic position, that can further limit your ability to breathe deeply, causing low lung volumes. And then when you get down to this issue of respiratory load versus the diaphragm, if there's an imbalance there, in other words, if your diaphragm can't overcome the load that it takes to breathe and bring air into the respiratory system, then you have respiratory failure. So there are a number of ways that we have to manage this. We'll talk some about both ventilation, which is a downstream a downstream intervention. We'll talk some about airway clearance. In my attempt to stay in the esoteric part of pulmonology, I also take care of patients with chest wall and spine deformity. We're not going to have time to talk about that, but if anybody has interest, I'd be happy to talk offline in between talks. So, airway clearance. Before we talk about airway clearance and how to support it when it doesn't work, let's talk about how it works typically for those of us here. There are a number of phases. The first, of course, is you have to take a big, deep breath in. As you breathe in deeply and your alveoli fill, it pulls laterally on the airways, which makes the airways bigger, opens up airways that may be plugged with mucus, and allows you to take a nice, deep breath. Then you cycle to a forced exhalation, and what happens initially is that your vocal cords will close for about a quarter of a second as you're breathing out. The pressure in the lungs will build up, the vocal cords open, and you have an explosive flow of air out of the respiratory tract, not unlike what would happen if you inflate a balloon and then let your fingers off. You can have a huge flow of air coming out. And some people have quantified what is an acceptable flow that would indicate that you can clear your airways. There's something called peak cough flow that some have used to be able to describe that. And I'll talk a little bit more about that later in the presentation. So there are a number of ways that you can compensate for an inadequate cough or airway clearance. The first is you can help a patient breathe in more deeply. Then, of course, you can help them breathe out more forcefully. Then you can do both together. And in addition, there's some other pharmacologic ways to help make mucus thinner and easier to clear. So these are a number of different ways of providing increased breathing in assistance or increased inspiratory assistance. The device over on the bottom left is something for doing what we call breath stacking, and it's essentially a mask with a one-way valve that allows you to breathe in but not out. And what you do is you counsel a patient to take a series of deep breaths, and then when they can't breathe in anymore, you remove the mask and have them breathe out as forcefully as they can. The device in the middle is called the cough assist, mechanical insufflator, and that can be set both to provide pressure to help a patient breathe in, and then to do airway clearance, you can cycle to exhalation. And I'll talk about that a little bit more in another slide or two. The device at the bottom right is called the Alpha 200, and it does what we call intermittent positive pressure breaths, which is just applying a pressure to help a patient take a deep breath in. It's quite popular in France. We don't use this device very commonly here. Actually, we really don't use it at all. Most people will end up using the cough assist to provide deep breathing. You can also do mechanical expiratory assistance. And in this figure here, from Michel Toussaint, who's a Belgian physiotherapist who's really described airway clearance and non-invasive ventilation wonderfully. What you do is there are two different ways of providing the support. The left two images are by providing forced exhalation by applying pressure on the chest. The two on the right is providing forced exhalation support by pressing on the chest and abdomen. The top image is with the patient at rest when they've breathed in, and then the bottom two images, the therapist is pushing on either the chest or the chest and abdomen to help them breathe out forcefully. So in theory, you can do cough assistance without any type of specific equipment that requires electricity or approval from an insurance company. But it requires somebody that can actually provide the training necessary to be able to do this properly, which would be a physiotherapist. So to do both inspiratory and expiratory assistance, as I just mentioned, you can do breath stacking with a manually assisted cough, or you can use the mechanical insufflator or a device like that. So this is the mechanical insufflator or cough assist. This is about the fourth version since it was developed. It was originally developed in the polio epidemics earlier in the 20th century. And then a physiotherapist from New Jersey, John Bach, sort of brought this out of mothballs and started using it again and has since popularized it. And in this version, what you can do, there's a nice monitor on the front of it, and you put in a inspiratory pressure and then an expiratory pressure. And then you can also put in a time that the inspiratory pressure is delivered and held, and then the expiratory pressure is delivered and held. And sometimes you can adjust the pressures based on patient tolerance and effect. And sometimes patients tolerate a much higher inspiratory pressure than negative pressure. And what can happen is when you're applying negative pressure during exhalation, that can collapse the upper airway and make it quite uncomfortable. And so there's no prescriptive way of doing this other than having a trained therapist working with the patient. In other words, you can't look at a patient and say what pressure they need. You need to have somebody that is comfortable manipulating this and working with the patient. And then more importantly, you have to have a trained caregiver, be it a nurse or a parent, that understands how to work with their child and assess both when they're trying to breathe in and then when they're trying to breathe out, and then apply the treatment appropriately. There is a new setting on this that allows the patient to actually have the breath applied when they're ready to breathe in, so a triggering device, not unlike what is used with mechanical ventilation. So I want to move into mucus mobilization, with the caveat that this is only done as an accessory to effective airway clearance with mechanical and exhalation. So the cough assist or something like that has to be the central part of an airway clearance regimen, but therapies to help with mucus mobilization can be a nice accessory. This is something called intrapulmonary percussive ventilation, and it's essentially a nebulizer that's delivered under pressure and with vibration. And it's felt that the vibration can help to mobilize mucus by shaking it off the walls. The pressure helps to maintain airway patency so that airways don't close during coughing. Then you can nebulize saline, either normal saline or hypertonic saline, to help thin the mucus further. And again, this is only something that should be done before the cough assist, so that the cough assist can then help to completely remove the mucus that's been mobilized. This device here is called the vest, or high-frequency chest wall oscillation. It's essentially a vest that vibrates at high frequency, and the theory is that it helps to liquefy the mucus and mobilize it somewhat. Very effective in cystic fibrosis, where, of course, patients have an intact cough. So for this to be effective, it needs to be done in conjunction with the cough assist or followed by the cough assist. In addition, there's some pharmacologic therapies that can be effective. Borrowing from cystic fibrosis, dornase alpha is an enzyme that's nebulized that helps to break up DNA from neutrophils. So it's very effective if you have chronic bronchitis, as is the case in cystic fibrosis, but that's not really the case in SMA or in Duchenne or any other neuromuscular condition chronically. However, it may have some benefit acutely. Hypertonic saline of 3 or 6 or 7% is also used quite commonly in cystic fibrosis and can have some benefit acutely in neuromuscular disease, but there's really no evidence at all that it has any benefit chronically. And the reason it's a bit of a challenge is that hypertonic saline will help to humidify mucus, but it does that whether it's thick mucus, thin mucus, or normal mucus. And so it's only really appropriate if you have somebody that has thick mucus that's difficult to clear. Once that's not the case, it's important to stop, or else you can have a situation where you're producing more mucus and it's completely iatrogenic and not because of the patient. In addition, anti-salivary or anticholinergic medicines that can be helpful in reducing the salivary burden. Antihistamines, patients can certainly have allergies, so antihistamines can be important. And if you have reflux, that can cause you to hypersalivate and produce upper airway secretions. And so considering antiacid or prokinetic therapy can be helpful in reducing upper airway secretions. So I want to move into another proactive approach that's been part of some of the more recent guidelines and was part of the document that Dr. Finkel and Dr. Mercuri put together a couple of years ago. So that's lung volume recruitment, or increasing respiratory range of motion. So this is the first study that actually looked at this, and this is a study looking at patients with a variety of different neuromuscular conditions. And what they did, if we look at the top image, which is compliance, which is the motion or stretchability essentially of the respiratory system, they did 5 minutes of deep breathing or intermittent positive pressure breaths and looked at the compliance. And to no great surprise, the compliance increased by doing just a brief 5-minute treatment with increased lung volume therapy. Another approach has been to try and strengthen the inspiratory muscles. And this was a study that was done in patients with Duchenne muscular dystrophy. And what they did is, for a couple of months before spine surgery, they used inspiratory muscle training that was titrated to the patient's muscle strength. And the parents did this for a couple times a day. up until surgery. And what they were able to show is that with the population, there is about a 3 to 5% percentage point improvement in vital capacity, which persisted through the postoperative period. And then what happened is they sent the patients home and said, we'll see you in a year and then in 2 years. And they strongly counseled them to continue with the inspiratory muscle training. The vast majority didn't, and so as you can see, the effect went away. And so while this is something that can help to improve lung function by strengthening inspiratory muscles, it's something that needs to be done chronically, and not you can't get a prolonged benefit from just a single intervention. This was a study that was done with the Canadian population looking at doing doing lung volume recruitment in is for the most part a pediatric population. And what they showed is that this is looking at vital capacity over time, and the line in the middle represents when the inspiratory muscle when the lung volume recruitment was started. And what this shows is that the rate of decline of lung function, of lung volume, decreased substantially. The only challenge with this, however, is that inflection point's at about 20% predicted for vital capacity, which is right around the floor effect in terms of natural history. They've since done some other work that showed that they actually, when this has been introduced earlier, can show a similar type of attenuation in the rate of decline. What they did also was looking at their data in a slightly different way, and what this represents, the light green line at the bottom, or the light teal line, represents the vital capacity that patients were able to produce through the duration that they followed them. The line at the top was the lung volume that the patients were able to produce with lung volume recruitment. So what they're able to show is that in the bottom curve, lung function, lung volume decreased over time, which is what you'd expect. But initially, with lung volume recruitment in the top curve, there was an increase initially, and then it did start to decrease. But what was interesting is the black line there shows that essentially the regaining of respiratory motion based on the difference between the patient's forced vital capacity and the lung volume, the inspiratory capacity that they're able to produce by doing by doing lung volume recruitment. And because that's going up, what it indicates is that there's been a persistent improvement in respiratory range of motion by doing lung volume recruitment. This is work from John Bach, who was the gentleman that introduced the cough assist and has made it quite popular. What he did here was he did maximum insufflation capacity, or lung volume recruitment, by using a manual insufflator, or essentially a resuscitation bag and a one-way mask. And what he was able to show is that some of his patients improved and some didn't. And he was looking at the difference between the initial and then the highest volume that the patient was able to produce, and that is in the maximum insufflation capacity, or MIC, in that first line there. There are some patients that improved and some patients that didn't. The patients that didn't improve had a maximum inspiratory pressure that was substantially lower than those that improved. And so the theory behind this is that the earlier you intervene, the more likely it is that you'll gain benefit. His group followed this study up and looked at the benefit not only of doing maximum insufflation capacity by doing manual insufflation, but also by doing it using a mechanical device like the cough assist. And that volume is represented as LIC, which stood for lung insufflation capacity. And so this would suggest, if you look over at the right column compared to the second from right column, that you can get a much more significant improvement in inspiratory capacity by using a mechanical device. And part of the reason was that this overcomes any type of bulbar dysfunction. And when you do a resuscitation mask breath stacking maneuver, you need to have the patient able to hold the breath in their lungs, and that requires bulbar function. Then finally, I want to move into respiratory failure. Typical symptoms that we see that would indicate respiratory failure would be morning headaches, because if you're chronically hypercarbic at night, the vessels in the brain will dilate in an attempt to try and remove carbon dioxide. When you wake up and you normalize things, that process goes away as the CO2 normalizes and the vessels go back to normal size. In addition, that can, if you're not sleeping well at night because of respiratory insufficiency, you'll have daytime fatigue, and in kids you can also see, failure to thrive because of a lack of rest at night, which is when patients rest and recover and gain strength for managing things during the day. In addition, if you see somebody that has a more rapid loss of function, be it respiratory function or physical function, that can also be a sign of inadequate rest or respiratory failure at night. So the typical way of approaching this is to do a polysomnogram or a sleep study. What we focus on is the carbon dioxide or hypoventilation, using either an end-tidal CO2 tracing or a transcutaneous tracing. The standard way by sleep medicine guidelines for diagnosing hypoventilation is when you get to the point where the end-tidal CO2 is above 50 millimeters of mercury for 20% of sleep time. I'm going to get back to that in a few more slides, as we're reassessing that and whether it's actually sensitive enough to pick up hypoventilation appropriately in patients with neuromuscular disease. What typically happens in respiratory failure is that you have respiratory insufficiency that presents at night and nocturnal hypoventilation before you have diurnal or daytime hypoventilation. I mention this because getting an end-tidal CO2 in the office is not a reasonable surrogate for getting CO2 readings at night. By the time you have daytime or diurnal hypercapnia, you've bypassed the point where you have nocturnal hypocapnia. So to really evaluate for this, you need to look at how the patient's breathing at night. So this is an example of some of the data that you get from a sleep study. The top tracing has periods of time when the patient's in rapid eye movement or REM sleep, which is where the black bars are. And that's where all of the muscles relax. And if there's going to be any compensation that a patient has to allow them to breathe effectively, that's going to go away when they're in REM sleep. So that's really the golden period where we can see dysfunction. And the thick black bar, about halfway down, that's the CO2 tracing. And I drew a red line at 50 millimeters of mercury. And you can see that there are a couple of periods during the sleep, typically during REM sleep, where you'll see the patient have a CO2 above 50 millimeters of mercury. Then what happens is the data is collated and put into a format somewhat like this. And at the top part, it's the end-tidal CO2 through the night. And there is about there's 17% of the sleep time with a CO2 above 50. And the guidelines that we've followed typically have been to call hypoventilation when you have a CO2 of over 50 for 20% of sleep time. So this would be called normal. The other thing that I want to point out is if you go down about halfway where it says oxygenation summary, this patient maintained normal oxygen saturation through the entire study. And so I point this out because doing a pulse ox study at night is not going to tell you whether somebody has hypoventilation. It can tell you if somebody has normal oxygenation, but it's not going to tell you whether they have hypoventilation. And so it's important to tease these two apart, keep these two apart. So the caution that I would offer is that what is significant and what's not significant hypercarbia. If a CO2 is over 50 for 20%, over 50 for less than 20% of sleep time, is that in fact normal? And one of the things that we're trying to better describe is what that transition phase is, where you have a patient that, when well, is breathing perfectly fine, but may be on the edge of having hypoventilation, so that if they get sick, they then need to have much more substantial respiratory support, or may in fact go into respiratory insufficiency. And I'll talk about that in just another minute or two when we finish talking about an acute management plan. So how do we support patients when they have respiratory insufficiency? So the first thing I want to talk about is how to not support them. Patients that have hypoventilation and elevated CO2 often are hypoxemic. The last thing that you want to do when you have somebody that is hypercarbic and hypoxemic is just treat one of those problems by putting a patient on supplemental oxygen. The risk in doing that is if you're chronically hypercarbic, your brainstem, the respiratory controller in the brain, will accommodate to a high CO2. And then if you're acutely hypoxemic, the brain will recognize that and continue to try and breathe more deeply. If you then correct that by giving somebody supplemental oxygen, then you remove the only remaining drive to breathe, and there's a risk of having worsened hypoventilation and respiratory failure. So the take-home message is that if you have somebody with respiratory insufficiency from neuromuscular disease and they're hypoxemic, you need to make sure that you're correcting the hypercarbia before you do anything related to the hypoxemia. So high-flow nasal cannula is a way that we often support young children who aren't able to or aren't comfortable with a nasal mask in place. The problem is that this does not provide ventilatory support. It provides some pressure support to help a patient perhaps overcome upper airway obstruction, but it's not a reasonable way to provide ventilatory support. And the same would apply for continuous positive airway pressure, unless you have documented obstructive sleep apnea. So mechanical ventilation requires two important parts. Arguably the most important is what contacts the patient. There are a variety of different interfaces. There are nasal interfaces, which can be either a mask over the nose or a cannula. There are oral interfaces that can be very useful for doing diurnal respiratory support or ventilatory support. You can have a mask over the mouth and nose. You can have a tracheostomy, and you can also have full body support, which is what we do for negative pressure ventilation. Ventilators typically for for non-invasive outpatient use are pressure ventilators. Inpatient ventilation can be, invasive ventilation can either be using a pressure source or using a volume source. So these are a variety of different interfaces that we have. The top one on the left is a silicone-based interface that has a little interface that, the contact point for the patient will bubble out as air goes through it to provide a nice air cushion. The device in the middle is an example of a cannula interface that goes in the outside of the nares with tubing that then is strung either behind the head or over the ears. Many patients like this approach because it takes away the large structure of a mask that can be difficult for patients to tolerate because of visual disruption. The device at the bottom left is a gel-filled interface that can be put in hot water to make the gel a little bit less viscous and can be then pressed on the patient to kind of mold to the patient's face if there's any type of asymmetry. The device at the top right, when I saw at a meeting a number of years ago, it's a mask that goes over not only the mouth and nose, but the entire face, not unlike what the people in Avatar wore. I thought it looked crazy, but we actually have some of our younger patients that actually tolerate it quite well, not because of Avatar, but because they seem to feel that it works nicely for them. And surprisingly, a lot of our infants and toddlers do well with this mask. Then the mask at the bottom right is an oral nasal mask over the mouth and nose. This is mouthpiece ventilation, which is a perfectly reasonable way of providing ventilation during the day. This patient is a patient with Duchenne muscular dystrophy. The right image is his wheelchair with his ventilator mounted to the back. The tubing is an articulating tubing that can be placed right up by the patient's mouth. If you have somebody that has upper extremity function, they can actually keep the tube in their lap and then lift it up to their mouth if they're ready to breathe. It works very, very well. And in conjunction with nocturnal non-invasive nasal ventilation can be a very effective way of providing continuous ventilation without having a tracheostomy placed. And this is an example of that device. The tubing itself can be mounted to tables. It can be mounted to chairs. Really, pretty much any type of a place that has a stable place for a clamp to be mounted to. You can have the tubing placed. And then in terms of ventilation, there are two general types: devices that are made for just intermittent use, meaning nighttime support, so BiPAP ventilators. And then there are ventilators that are made for continuous use, which tend to be about twice as expensive. And so when we start a patient on respiratory support, we'll often start with a BiPAP nocturnal non-invasive ventilator, as opposed to one that's able to be used continuously. And finally, I just want to spend a little bit of time talking about acute management. So what is the action plan when a patient begins to get sick? We spend a lot of times finding the support that patients need for daytime support, but when things change, we need to change the plan also. So I use this as an example. So I talked briefly about peak cough flow, which as it decreases indicates that a patient's not able to cough effectively. And then end-tidal CO2, or transcutaneous CO2, is what we use to define when a patient begins to have respiratory failure. And so I put this up with thresholds. 270 liters per minute is the threshold when well, that if you drop below would indicate that when you're sick, you're going to have trouble clearing your airways. And then 45 for CO2 is the upper limit of normal. We tend to get quite concerned if the CO2 rises above 50, and very concerned when the peak cough flow drops below 160. And so there are thresholds, there are ranges of concern. And if you have a patient that acutely is in the low normal range, the concern is that when they get sick, they may lose muscle function or muscle strength to the point where they'll drop below the threshold that would get us concerned. In other words, if you have somebody that is close to having a high CO2 or having an abnormal CO2, when they get sick, that might be somebody in whom the bottom would fall out, and they would end up in the intensive care unit with substantial therapy. And so it's important not necessarily to have that patient on non-invasive ventilation, to be aware that they're going to have an imminent need when they get sick. So the acute management plan involves a number of things. The first and foremost is increasing airway clearance. And I think that's probably the single biggest flaw that occurs in care situation where the clinicians are not comfortable managing or experienced managing patients with neuromuscular disease. And the first thing, of course, would be using an exsufflator or cough assist, augmented by chest physiotherapy and then suctioning. And those are really the three big components of an effective airway clearance routine. And then pharmacotherapy, albuterol can sometimes be helpful in addition to mucolytic therapy, which can just be doing normal saline or hypertonic saline. And then, of course, if this is precipitated by a bacterial infection, then starting an antibiotic can be very effective. And we tend to err on the side of treating as opposed to not treating. And then ventilation. As I mentioned before, the last thing you want to do is start with supplemental oxygen. Oxygen is good, but only if used when somebody's respiratory failure is supported properly with increased ventilation. And increased ventilation can be either non-invasive if the patient's able to tolerate having a nasal interface on for the duration that they need ventilatory support, or if that's not feasible, then shifting to invasive ventilation with an endotracheal tube.
So there was a question on here. Now I can't read it. So the question from the audience was, is there a reason in SMA that your inspiratory muscles would be affected differently than expiratory muscles? And then how does the treatments that we've discussed earlier this morning affect that?
So the only real inspiratory muscles that are deeply affected in SMA are the external intercostal muscles, which help to elevate the ribs. the primary inspiratory muscle is the diaphragm. That tends to be unaffected in SMA. Having said that, we've all seen patients with early SMA2 or SMA1 that have very flaccid chest walls. And what happens there is when patients breathe in, normally the chest wall should either stay in one place or move outward during inspiration. And in patients with SMA, it actually moves inward, which means that your diaphragm has to go down further and you have to expand your lungs further down into the abdomen as opposed to expanding outward. I don't know if that dodged the question or answered it.
Next is, does intubating a patient with SMA during an acute process decrease muscle strength post-extubation?
No, it allows you to support weak muscles that led to the acute respiratory failure to begin with. And some would actually argue, including John Bach, that if you intubate early in an acute respiratory illness, that gives you a much easier route to be able to clear the lower airways. And so acutely, I don't think that there's anything wrong with intubation. The biggest thing, however, is managing the patient post-extubation and using a different approach than you would for somebody perhaps out of the operating room or somebody with intact respiratory muscles. And in part, if you think about what the typical counseling is when an endotracheal tube is removed, there's somebody that's usually hollering, cough, take deep breaths, cough, take deep breaths. It's a little challenging for somebody with SMA to do that. And so at our center, we've put together a protocol to help manage patients post-extubation. What that usually requires is assigning a respiratory therapist to not leave the bedside until the patient's supplemental oxygen is back to either room air or back to what their baseline is. And that would require doing a series of cough assist treatments, suctioning, and then moving forward. Related to that, one of the other things that I just want to comment on is that having hypoxemia is not a reason to stop doing a cough assist. And what happens is that if you're mobilizing secretions peripherally, and then a mucus plug happens to lodge down into another airway, you're going to be hypoxemic transiently. If you just leave the mucus there and turn the oxygen up and then come back and turn the oxygen down, the patient's SpO2 will probably go back to where it used to be. But that's not because the mucus has been moved, it's because of hypoxic pulmonary vasoconstriction has shunted the blood away from where the mucus has lodged. And so if you have a patient whose SpO2 drops acutely during airway clearance, it's important to give them some supplemental oxygen, but continue until you can remove that supplemental oxygen and have a normal SpO2.
Yeah, and I think to add to that in terms of intubation of patients with SMA, I'm actually not afraid of intensivists or emergency rooms intubating the patient. I think that that's a good thing, right? The patient needs to be supported. I think the conversations around extubating and making sure the patient is ready, I think that's where a lot of people who aren't used to taking care of patients with neuromuscular disease will often try to extubate too early and then say, oh, the patient's failed extubation needs a tracheostomy tube, which may not be true. And so I think that in that case, having an expert in neuromuscular disease is very helpful. Another question is, who orders inspiratory muscle devices, and what devices do clients typically use at home? Could a physical therapist use this in an outpatient setting?
Yes. There's a device called the IMT, which is produced by, I believe, Respironics. It's a device that looks like a fancy whistle, and it has a spring that can be in a little knob at the end that you can screw down to make it either harder or less hard to breathe through. And at least the study that I quoted, what they actually did was they would do a maximum inspiratory pressure maneuver, and then from that assess what would be a slightly submaximal pressure that would be a reasonable training setting for a patient. So it's certainly within the realm of a physiotherapist to do inspiratory muscle training, and that's exactly what we do at our institution. We have one of our physiotherapists that has taken an interest in neuromuscular disease come in and start inspiratory muscle training protocols for patients who have both an interest and have the muscle strength to respond.
What are your thoughts on using full face mask for non-invasive ventilation in young children given the risk of aspiration?
As long as you have somebody that can follow the patient, assess the patient properly, it shouldn't be an issue. We worry about patients on full face mask or oral nasal masks where there's not adequate surveillance, and so, or especially in patients that don't have the muscle strength to reach up and remove the mask if they're beginning to have difficulty.
And then, are there any reliable ambulatory end-tidal CO2 measures that can measure nocturnal end-tidal CO2 in a home study?
Reliable? No. There's typically, if you want to do nighttime home monitoring, you need to use a transcutaneous CO2 monitor. It's much more stable. The problem is that with an end-tidal CO2 monitor, it's a cannula that fits in the nose, and if it becomes dislodged, or if the patient decides to breathe through his or her mouth, you're not going to get a good reading. And so you could have a falsely low end-tidal CO2 that would make you think that the patient's doing perfectly fine when they may not be. So home monitoring needs to be with a transcutaneous CO2 monitor.
Thank you very much for everyone's questions. My last comment is, I think that with all the new therapies that have come on board where people sometimes think that we have a cure in our hands, we actually don't. We have a treatment, and that respiratory care and respiratory management in these patients is still very important. Thank you.
Great, thanks.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.